if ultimately what's happening with prescribing statins isn't really a judgment call so much as here's your markers, here's the result, it's a formula, and that's what the doctor's doing anyway, what is the difference between an AI doctor and a human doctor? What is the benefit of having a human involved in this? This is Generation Health. Every week we bring you guys the latest in news, cutting-edge research, and time-tested best practices helping you live longer and better. Sitting opposite me, PharmD, certified strength and conditioning specialist Dante DiMatteo. How are you?
I'm doing well, thank you. How are you?
I'm good.
How are you guys doing?
We haven't introduced him yet, so we can't address him.
Makes it sound like a mystery guest. Just me.
Just you. Just Josiah. Surprise!
Here, surprise, surprise.
Engineer extraordinaire, Josiah Schweinberg.
That's high credibility.
You definitely have cred.
Is that so?
Mm-hmm.
All right.
With somebody.
I'm feeling good now that I got
crud.
Yeah.
This is going to be a wild one, guys.
Buckle up, baby.
Yes. My name is Tyler
Baklava.
Andrews. And I am your host and theoretically ringleader, but I don't know. Today it's maybe not. We'll see. Dante, what are we talking about?
We're going to do a little mini research review.
Okay.
So we're going to talk about prescription-less statins, and we're also going to talk about the effects of different concurrent exercise programs.
Oh, wow. Okay. Those are separate things, not the same thing.
Exactly.
Got it. Okay. All right. First, I want to bring you guys just one quick behind-the-counter news segment here. According to a new study published in JAMA Health Forum, biosimilar drugs have not consistently lowered out-of-pocket costs for consumers with traditional health insurance. Many modern medicines are biologic agents or molecules derived from living organisms. They can't be replicated in a lab just by stapling a few different molecules together. They have to be produced in a particular biological fashion, thus the name biologics. Biosimilars are effectively the generic forms of those drugs. Typically, generic medications are useful for helping to drive down costs to the consumer. They provide competition and market pressure to bring drug prices down. Unfortunately, according to this new study, that's not exactly true for biosimilars. While the cost of the biosimilar drugs themselves is usually 15 to 25% lower than the brand name reference drug, that is, it does not appear that those savings end up being passed on to the typically insured consumer. Total annual out-of-pocket expenses stayed the same or even went up for consumers in the years preceding and immediately following the release of biosimilars to the market in this research study. The researchers did not offer any explanation as to why this might be the case, but it is definitely not the results we were hoping to see. That's what I got. Dante, tell me about these research studies.
All right. The first one, title of this particular study is a technology-assisted web application for consumer access to a non-prescription statin medication.
I love how fascinating these
great title, always great
are.
titles. So all that essentially means is that an app was developed where consumers, patients, however you want to frame them, can after a selection process, they were able to answer a certain set of questions via web app to spit out an answer on the other end that allows them to determine whether or not they would be a candidate for cholesterol lowering medication. And in this case, it was rosuvastatin 5 milligram.
Okay.
And so this is particularly interesting to me because, we have talked a lot about statins. We've talked a lot about cholesterol lowering medications. And then there's also this, for some people who aren't aware, there's even this history of drug makers trying to push for certain statins, certain cholesterol lowering drugs to be available over the counter. Such attempts have generally failed just because the essentially imagine Tylenol. There's a drug label. on the box. You can look at it. It tells you what it is, what dose, how much to take, who should take it,
Right.
when to talk to your doctor if you're experiencing X or Y. So imagine the same thing for your cholesterol medication. A lot of people, maybe those who are overly health literate or they have a health background, they might be able to look at that drug label and correctly determine, hey, I am a candidate based on some of this blood work or based on these factors. Maybe I am a good candidate. I can start taking this medication. The point is the vast majority, I think it was under 50% of people in one specific study chose the wrong dose, or they just chose wrong altogether. So the point is here, looping back to this paper, by using an app, sort of a guided approach, you can sort of bypass your doctor, answer these questions, sort of an algorithmic process that we'll talk about, and then it determines whether or not you can purchase essentially a statin medication without a prescription.
All right. So you mentioned Tylenol as a comparison that the average consumer can look at a bottle of Tylenol and know between what's written on the back of it and how they're internally feeling, proper dosage, and all the rest.
Mm-hmm.
But Tylenol is used acutely. That's I don't take Tylenol every single day. I take it when I'm having a headache because I didn't drink coffee.
Mm-hmm.
Theoretically, a statin is a recurring, consistent, you have to take it all the time medication.
Right.
So the in my mind, the likelihood of or the possibility of something going wrong because of this seems a lot higher. Is that not the case?
I think that's a great point, and maybe in a different sense than what you're thinking.
Mm-hmm.
Now, when we look at the medication that they specifically used in this new trial, it is rosuvastatin, Crestor, 5 milligrams.
Okay.
So it's a lower dose. So basically, in technical terms, it's a moderate intensity statin.
Okay.
The vast majority of people do tolerate this very well, and they do tolerate it well over the long term. And that might make some people unhappy, but in general, these medications work well. There are less general issues with rosuvastatin, Crestor at this dose than even some of the higher dose statins, the older statins that were used years ago. So the point is they chose one that's pretty well tolerated, where theoretically the person who's going to be taking this on an ongoing basis doesn't have to worry about those issues or side effects so much.
Okay.
Now, to your point, I see the issue with the average person maybe having to manage this sort of stuff on their own. So if you go to your doctor, you establish a relationship, you determine that cholesterol lowering therapy is a good option for you, then they do some blood work, they look at some baseline measures, and they tell you exactly when you need to follow up. It's just a lot of it you don't have to think about.
Right.
They bring this stuff up at your yearly physical. They bring this stuff up now with, My Chart and sort of these interactive features that they can send you a text, they can send you an email. It's very integrated. Mm-hmm. So doing it the right way, so to speak, I think works a little better in my mind, because you have all these checks, and it's not so much that you're afraid that 5 milligrams of Crestor is going to throw you over the edge and you're going to go into, God forbid, liver failure or develop severe type 2 diabetes because of it, or whatever the fear is. It's more so that do we really want to trust the average person who's worried about their career, their family, all these other things with now
one more thing,
managing their own medication?
Yeah.
And that is my biggest concern with this. Now, when we'll get into more of the details, that's not how this app works. It's not just a questionnaire, and then they kick you out the door.
Okay.
It's very much then integrated. It tells you when to follow up. It tells you where to go. It tells you everything to do. But the point is, the medication isn't going to your pharmacy. It's not even going to your doctor. It's just being shipped to you.
Wow.
And so it's bypassing some of those checks and balances that we're associated with when we get a prescription filled.
Okay. So tell me about the study. Tell me about the app. Is this this is just a study, right? This isn't actually implemented on the market, correct?
It is not, but they are looking for, essentially, they're looking for FDA approval as a medical device.
Okay.
Via this software, if that kind of makes sense.
Yeah.
And so that's the hope. But yes, it's still very much in its early phases. Right now, it's this paper is still, as of March 19th, is still a pre-proof, not a preprint. It's a pre-proof. It still needs some additional corrections, but it's going to a journal soon. So it's locked in. I don't know what the timeline on something like this would be, but to answer your question more simply, yes, they're gunning for an integration of this kind of thing.
So this is serious.
This is serious.
Okay.
So the study, they looked at about 1,200 people, all said and done. There was a self-selection process, all said and done, 1,200 people. Essentially the app's advice, so looking at the results quickly, the app's advice matched the clinician's selection in about 90% of the cases.
Wow.
So the app said, here's what we think you should do. And then they blinded, so to speak, the clinicians, and they looked at what they told the patient to do, compared the results, and in roughly 90% of those cases, they were on the same page. So that's pretty solid.
Yeah.
That's a legitimate congruency on that aspect. Then 98% of the individuals who ultimately were recommended this 5 milligrams of Crestor, they used the medication correctly. So not only was it matching algorithm to clinician, they also got the medication and they were adherent in that 6-month span that they were measuring them.
Wow.
So that was the very generalized findings. And then they also, to add to that, they, of course, we're talking about cholesterol lowering. The participants' LDL cholesterol dropped by about 35.5% at 6 months from a baseline average of 140.
Wow.
So that's, as expected, that's
what it's
supposed to do. And
right.
Again, just speaks to the adherence of the participants. So there's a lot more to the selection process though, but I think you're asking really good questions here. That's helping instead of me just, tearing through some of the stats. But if I did want to clarify one thing. We are talking about something called primary prevention, which we've mentioned in other settings. But in this case, this is using a cholesterol lowering medication for primary prevention for somebody who doesn't have cardiovascular disease, who has not had an event.
Yes.
And they do not have additional coexisting conditions that would render them a candidate for higher intensity statin therapy. So this is a very specific kind of sliver of the population. I imagine that the app sort of told them if hey, you listed these 10 things, these other, maybe you have a aortic stent placed, or you've had a history of a stroke. This would say, do not use this statin. You are a candidate for another thing.
Go talk to your doctor.
That's what it tells you. Go talk to your doctor. So I want it to be clear that it's not just like, oh, we're just going to get as many people on 5 milligrams of Crestor as we can. There's a lot more rigor to what they, to that selection process.
Got it. You mentioned self-selection. I always think that's an interesting thing when it comes to studies, that the people that sign up for those things, there is some sort of psychological element to the fact that they're willing to be a test subject.
Right.
There is some self-selection element happening. But in this one, it's almost like it's doubled down, because the whole point of the study is whether or not people can self-select for a statin to some extent. Mm-hmm. And obviously it's guided, and the app is part of what's determining whether or not that's a good idea. But it is fascinating that with over 90% accuracy, they were able to self-select and do so correctly. Mm-hmm. That's really cool.
It is. And there's a lot that I can take from kind of what you mentioned there. The first thing that comes to mind is how simplified really the process has become when determining if somebody is a candidate for medication like this. So yes, when you go to your doctor, there is a conversation, there's shared decision making, they're looking at other medications you might be taking. There's all these factors that go into it. But what this app employs is something called the pooled cohort equation.
Okay.
And so essentially what this does for certain populations, I believe essentially what comes out at the other end is a 10-year ASCVD risk score that's calculated. And it's for individuals 40 to 75. And it looks at things like age, gender, weight, BMI, blood pressure, things that are relevant to atherosclerotic cardiovascular disease. And so it's sort of a foolproof system. You know what I mean? Your doctor in their software, all of those risk factors are being punched in. And so you get that risk score in which they have to make a clinical decision based upon. And then the algorithm is essentially asking all the same kind of questions, except just framing it directly to the patient. And so it's like, okay, well, now what are we doing? We're just going to bypass the doctors. Is that really what we need to be doing here? And that is certainly some of the critique. But again, it's been so well established that cholesterol lowering medications are important, and determining the dose of the statin based upon that score and the other risk factors is really important. And so just let's see if we can get more people access to this generally simple process, and, see if we can, that's the thought, is that there's so many people out there who have high cholesterol, who are at risk of cardiovascular events, and they're being underserved. And so we need to get this out there to them because of this simplified option.
Yeah.
But it's just not that, it just doesn't seem that quite clean cut.
It does seem like there's just maybe it's just that we're not used to it.
Yeah.
That this is a shift.
Mm-hmm.
I know we've got oral birth control is now available over the counter.
Mm-hmm.
And that too kind of feels like a step. I'm not sure the direction, but it's a step. Things are changing and moving and shifting. How is this? What's the long-term prospect for doing this? I mean, are we talking about AI just takes over and you're going to go to the doctor, the AI doctor, the robot doctor, it's going to read your results. And I mean, if ultimately what's happening with prescribing statins isn't really a judgment call so much as here's your markers,
mm-hmm.
here's the result, it's a formula, and
mm-hmm.
that's what the doctor's doing anyway. What is the difference between an AI doctor and a human doctor? What is the benefit of having a human involved in this?
That is a great question that I don't have a perfect answer to. But I mean, we're in the business of pharmacy, and it's not just a business, but it's a day-to-day grind to maintain and to build relationships and to build trust. And so to kind of bypass some of that is ultimately, just to kind of restate what you're saying, is what makes this uncomfortable. I think that this is useful. I really do. Because I'm the type of person that, when you're thinking about maybe a personal healthcare intervention, you kind of maybe like to read some things and do some things on your own and process it on your own a little bit. And maybe you punch in some numbers on the calculator yourself, and then you equip yourself with that when you go talk to the true expert. I think I fall into that camp. The problem is where, some of us are know-it-alls, and you say, you know what? See, this is why I don't need my doctor. I don't need the expert. I know exactly this spit out exactly what I needed, and all of my conditions can be managed as such. I think we just have to be careful about where we apply this to. I think the over-the-counter birth control, I mean, there's multitude of opinions on that. The progestin-only pill that's on the market, I get it. I think for the proponents of something like this goes right along with that because it just seems so low risk. But anytime you are bypassing that relational component with a provider, I think you just have to be careful. If this steers people, which I think it does, if this steers people to the pharmacy, if this steers people to go get your blood pressure taken at this place, if it steers you to go get your blood work done at this place where there's a person there doing it, I think that captures some of the importance with relationships and connecting this to a person that you can talk to about all those sorts of things. But if it's just, we're mailing you a kit, prick your finger, we're mailing you this cuff, measure it yourself, we're mailing you this, fill it out and send it back, and you're just out on an island as this really motivated person, managing your health, I think it can definitely get a little dicey.
Yeah.
If that makes sense.
Yeah.
And then the other layer to it is the individuals who are more likely to do this are those that have a higher level of health literacy as it is. And so they're generally more knowledgeable. They are more motivated. They are in a little bit of a higher socioeconomic status. And so it's like, really, did these people need it anyway? What about the people who aren't comfortable with apps and don't have access to certain computers and to certain technology? The main purpose of this, again, was to increase access to a really low risk medication to such a high prevalence problem. Are we really capturing it by a sophisticated app that
it's a good point.
If most of the underserved, under-medicated people are those that don't have access to this sort of stuff anyway, are you really going to be moving the needle so much?
Yeah.
It's like, it's tough.
Yeah.
I mean, you can make that argument about supplements. You can make that argument about exercise programs.
Sure.
You can make that argument about exercise coaching and expensive gym memberships. You can always make those sort of arguments, but I think that it's, you have to at least mention, that there's still a whole other side to it in that respect.
Absolutely. Absolutely. Man, that's a big idea. And I have lots of mixed feelings about all of that.
For sure.
But I guess,
and it doesn't mean you don't do it.
Right.
It's just their sort of rebuttal to that was, this starts as a web-based app. And yes, if you have an iPhone or you have an Android, it's going to be easier for you to find. Or if you are really motivated and really educated, it'll be easy for you to just fill this out and boom, next thing you know, you have 90 days of Crestor at your front door.
Right.
But the point is, they integrate this in grocery stores and community centers and kiosks, and sort of like a place where someone can go and just in 5 minutes, they have an answer. In 5 minutes, they can punch in some of their basic information, or at the very least, it points them to say, hey, if you don't have this blood work, or if you don't have a blood pressure screening, it's really easy. You just go right over here.
Right.
And so I think there are ways to bridge that gap. But in general, it's like you put this tool out there for people that are already probably going to their doctor,
Yep. I'm about to go see my doctor again for my annual physical and get all my blood work done and all that. And, I think I'm capable of using an app. I'm a relatively intelligent person. Heck, I host a podcast about health and supplements and pharmacy and all that stuff all the time. So if I can't do this, come on. But
Right.
But the reality is I don't trust myself to do it. I would really rather have somebody else who has some wisdom and experience look at it and go, no, Tyler, this is probably a good idea. Or no, don't do that. Try this instead. Man. But I guess this is the way things are going. And it's just one more tool. Nobody's saying I have to use this or I don't have to use it.
Mm-hmm.
It's just another option.
I felt that the idea of this OTC statin conversation, some of our listeners might
absolutely bristle
their interest,
at that.
Their interest would be piqued.
Yes.
Hey, it's worth discussing. It's worth presenting the news. It's worth. I mean, this literally just came out a few weeks ago at the time of this recording, and so just to give our peeps a feel for what's always coming is I think a good thing. Not to sway you per se, but just to say that this is kind of the way things are.
And this is not, this is still pre-press. This hasn't been published yet, and they're seeking FDA approval. So you're not going to see commercials for this in the next couple of weeks or anything like that, but it is on the horizon, and people need to be aware. Dang. All right. Well, what was you said there was another one, right? Another study you wanted to get into?
There was.
Okay, this one's about exercise.
So this was another one that just was just published. It's in the Journal of Human Kinetics. The way I found out about this, there's a fellow, Michael Zordos. He's one of the well-respected researchers in the, really the health and fitness space. He works he works and teaches out of a lab at Florida Atlantic, I believe. And so that's where much of this research takes place. He is super, super knowledgeable. There was, of course, many other artists. There were many other collaborators on this paper, but this is where I initially found out about it. The title of this is The Effect of Time-Equated Concurrent Training Programs in Resistance-Trained Men. So if you listen to this for the purpose of the, what will probably be a very catchy title that Tyler will come up with, OTC statins, and then you hear the effect of time-equated concurrent training programs in resistance-trained men, then those people probably just slammed the computer shut the TV off and moved on.
Right.
But if we look, so what is a concurrent training program? All concurrent training is just combining elements of resistance training with elements of conditioning or cardio or aerobic training.
Okay.
So it's one program with those things in it. And so for those of you who actually listen to what we have to say in regards to exercise, that is what the exercise guidelines are a proponent of. That's pretty much what everybody is a proponent of anyway, is some sort of concurrent training. Certainly one of these facets is always better than none. But it's the integration of these two that often draws some critiques, some different thoughts, maybe some issues for people, some confusion. And so this study aimed to look at, if we looked at different types of concurrent training, how did this affect their performance across the different domains that they're talking about?
Sure.
So they broke it into 4 groups. And so there was a resistance training only group, 3 days a week. There was a resistance training plus cycling group, 3 days a week of resistance, 2 days a week of 30 minutes of cycling.
Okay.
And you'll see these groups keep building upon each other. The resistance training, the next group is resistance training plus high intensity interval cycling.
Oh, okay.
Final group was resistance training plus circuit resistance training. And so what that is, to kind of distinguish it from the high intensity group, they essentially, the exercises that they did the resistance training portion with, it was a bench press, shoulder press, squat, barbell curl, certain very, fundamental movements.
Yeah.
They did that in their specific, they did the same resistance training days as all the conditioning people, but then they took those same exercises and they just put them in a 30-minute time cap and said, you have to do those 4 or 5 exercises straight through for X amount of reps and get as many as you can in the allotted window.
So they turned it into CrossFit.
They turned it into it sounds CrossFit-ish, yes.
Is that? I mean, it sounds exactly like what that is.
Exactly. And so I thought that was the way that he thoughtfully broke those groups. I thought was interesting because again, you do have people who have pledged their allegiance to, well, I just lift,
right?
Or I do some lifting, but I prefer to take these long bike rides, and it's easier on my knees and whatever.
Sure.
And then you have these other people who are like, I like to lift, and then I like to go really hard in my conditioning.
Yeah.
And then you have people who are like, I hate the treadmill, and I want to lift, and I just want to keep lifting more under some sort of time domain.
Right.
In looking at these results, it's probably easier just to read it how they framed it.
Okay.
So they measured a whole bunch of different things. They measured back squat strength, bench press strength, quadriceps, muscle thickness, the muscle thickness of certain muscles of the pec, VO2 peak, maximum workload. And so all in terms of watts. And so they looked at all types of, basically, for the sake of conversation, just measurements that look at your aerobic performance measurements that look at hypertrophy, so muscle thickness and such. And then also, are you lifting more weight? Are you getting stronger?
Yeah, it's like they tried to calibrate this every way they could.
Exactly. So let's go back and look at some of the results. I want to present these in the simplest way possible.
Okay.
So in general, if we look at just the cardiovascular outcomes that we mentioned, so these are things like VO2 peak or the max wattage that they were able to put out on the given cyclical device. So only the moderate intensity group, so like the 30 minutes of cycling continuously group and the high intensity cycling group, those were the only groups that really saw a meaningful improvement in either of those measures.
No kidding.
Yes. And so it's important, I think, in that context to note that's ultimately why we advocate for kind of trying to keep, as you're getting started or you're just trying to hit a catch-all approach to exercise. That's why we advocate leave the resistance training as the resistance training. And if you can, and you can work it in, try to leave your cardiovascular exercise as your cardiovascular exercise. And that's walking, biking, cycling, running, swimming, rowing, all of those sorts of, we call them monostructural or cyclical modalities, things that you can do continuously.
Right.
And it's harder. There's a whole separate conversation in and of itself of why it would be harder for just doing bench press, squat, barbell curls, like in a higher intensity setting, why that doesn't quite lend itself as well to those cardiovascular outcomes. You just can't quite elicit the same. You're limited by the muscular endurance component of those exercises.
Absolutely.
That don't let you, whereas you can push those other characteristics on the cyclical modalities.
Yeah. If you do a back squat of substantial weight for 10 reps, you're probably out of breath by the time you quit doing it, even though it's theoretically not a cardiovascular exercise. It just, the way it works, it drains your breath.
Exactly.
I can't imagine trying to do that in a timed fashion and thinking that that's going to be cardiovascular exercise.
Exactly. They also stated that the data suggested that the interference effect on maximal strength and hypertrophy can be avoided when the aerobic training is moderate intensity cycling, high intensity cycling, or novel barbell circuit for 1 hour per week and on non-resistance training days. So that's
okay. So
that's a lot, but that pretty much captures what the heck I really care about with this whole thing.
So the interference effect, are you talking about, I think I've heard that, that doing cardiovascular exercise can interfere with hypertrophic benefit of lifting weights, that you won't gain as much mass or get as strong if you're also doing cardio at the same time.
Exactly.
Is that what we're talking about?
Exactly. I'm glad you brought that up because I really wanted that concept to be the bulk of this discussion.
Yeah.
Because as you can see, sometimes it's a little dry just running through the statistics of a trial, as important as I think that is.
Yeah.
It's these big concepts that stand out. And so the interference effect is something that, dates all the way back to the 80s, and for good reason. In some studies that were looking specifically at athletes, so strength athletes, let's say, as they were focused on their resistance training, once they started pouring in these extra bouts of conditioning and running and sprints, they noticed sort of this drop off in their ability to maintain or increase their strength, maintain or increase their power.
Yeah.
Characteristics that are really important for the athletic population. And so that thinking was pervasive through today, arguably. Yeah. But to a much lesser extent. And that's what papers like this set out to try and, help try to expand upon. And so ultimately, yes, that what you said is the interference effect.
Okay. And this paper is saying that that's not a factor?
Yes. They're saying that you can still absolutely get stronger and you can get bigger, talking about hypertrophy, with a little bit of aerobic training in your overall plan. And now there's a lot of, there's definitely a lot of nuance there. I think if you, as always, have to take this by kind of case by case. If you're looking at a sprinter, if you're looking at an Olympic weightlifter, these things where you have to produce lots of force fast, so expressing high amounts of power, I think if you're overloading somebody with lots of conditioning, then by default, there can be this drop off in that peak power that they can maintain. But for the average person, this interference effect is not something that you just want to totally ignore. And not everybody thinks this way, but I have heard the sentiment in talking with people who have started lifting and they've really taken an interest in lifting, that they've then prioritized it so much so that I noticed that as soon as I started walking on the treadmill for 30 minutes after my session, or I tried to do a little bit of conditioning before I lifted, and I noticed like my bench press went down 20 pounds and my squats felt way heavier, and that's not good. And I probably need to do less conditioning, when really there are strategic ways to sort of balance all of those things.
Makes sense.
But again, that interference effect, that concept, I think is really important. It's interesting. It's been around for a long time. But it's not that it's been fully disproven. It's just there's been tons of research like this that has helped put everybody's mind at ease.
Okay. All right. So the punchline for this one is that resistance training, that you get stronger if you do resistance training, but that if you want the cardiovascular benefits as well, you really need to add in cycling or some form of cardiovascular exercise, whether it's high intensity or a lower steady state thing, and that you should have that primarily as a distinct and separate exercise routine, not worked in so that you're doing it. I'm not articulating this well.
No. I know what you mean.
That you're not jumping from the bike to doing thrusters to, doing something else to jumping around all the time, that it's a separate workout routine, that it gives your body time to adapt there.
Exactly. So theoretically, if you're trying to maximize both of those things, like in the way they had it organized in this study, for example, is Monday, Wednesdays, and Fridays, I believe, were resistance training days. So every other day was basically the same exercises across those 3 days,
right,
in different rep ranges. And then in the gaps, the Tuesdays and Thursdays, those are the days that they either had the high intensity cycling, or they did 30 minutes of continuous cycling, or they did 30 minutes of barbell work. And so, which sounds very similar to a program we're working on. But that very simple template, I don't want people to lose sight of that. I know 5 days can be a lot, especially as if you're somebody who's just getting started, but that is almost an optimal setup. If you just, on the back of a napkin had to sketch out a weekly plan for somebody,
right?
Like Monday, Wednesday, Friday, separate your resistance training days, try to hit kind of full body exercises on those days. And then in the gaps, just do enough conditioning, enough cardio, whatever you want to call it, that you feel that you can recover from. And so that is going to be different for each person, always.
Yeah.
This study in particular was a very small study. I think there was only 20 or 25 participants. So it is limited in that sense. And it was done in mostly trained individuals. So we have to be careful, about who we extrapolate this to.
Yep.
But in general, I think it speaks to the very important concepts that we've sort of hashed out. The other interesting thing is if you, there were some increases in hypertrophy in the groups that had the resistance training plus, as you would imagine, the additional barbell training.
That makes sense.
So even though it was done in a suboptimal way, how do you get bigger? You want to make sure that you first and foremost do more volume, do enough of the stuff that you want to grow, essentially.
Yep.
Do it with great technique and through the full range of motion, that sort of thing. So there's probably further ways to optimize muscle growth than from the perspective of that circuit group. But it speaks to, if you just do a bunch of work, you probably, you can, so long as you can recover from it, if you just do a bunch of work and you progress it over time, you're probably going to put on some muscle size. So that, but you're also not necessarily getting the cardiovascular benefit that you would hope for.
Makes sense.
So, I just love thinking about this stuff, because CrossFit, you read something like this and you're like, wow, it's probably like the most suboptimal thing I could be doing
right.
to develop these different systems.
Right.
But a well thought out version of whatever modality you like.
Bingo.
Is what's going to, first and foremost, what can you stick with? Secondly, can you thoughtfully organize it in your life that it works? Because who cares about the interference effect if you're just skipping conditioning altogether? I don't really care about the 20 pounds on somebody's bench press if it comes at the expense of always skipping their boring steady state work.
Right.
Or if they're somebody who, they have the 30 minutes to do the conditioning, but they just can't right now engage with the continuous ride the bike for 30 minutes, walk for 30 minutes, run for 30 minutes. They just can't quite engage with that. Breaking it up into an interval-based approach like they did in this study, where we see it does improve their max wattage, it does improve their VO2 peak, it does work for those things. So maybe you're that person who it looks more like interval style training. If that's what you're going to do,
right.
If that's what you're going to adhere to, pick that. Just because someone said to do all the zone 2 stuff, do what you're going to stick with. And then as you build the momentum, then you can get fancy. But if you're the person who is currently skipping the conditioning because you're worried about losing some of the bench press gains, or you're worried about whatever, and in the long run, it doesn't really work. It doesn't really matter. Your performance in that workout, because that's really what we're talking about here. Your performance on that given day is going to suffer a little bit for the sake of you looking 5, 10, 20 years down the road of look at all this conditioning that I put in my reserve, my savings account of fitness adaptations. So that's still the big picture here.
I love how geeked out you get on this stuff.
We're geeked up.
Well, that is what we've got for today. You can find all the details of this, our email newsletter, any past episodes or episodes of the show that started all this on our website, askjoedimatteo.com. That's AskJoedimatteo.com. That is also where you can find a bunch of supplements and natural health supplements that can help you live better and longer. If you have a question, we want to hear about it. Questions at askjoedimatteo.com. Big thank you, as always, to Josiah Schweinberg, the engineer, Michael Deppish, our editor, Joyce Gibb, our nurse practitioner who handles private consultations. Diane Silverman manages our product. Terry does scheduling. Cecilia does distribution. That's Dante DiMatteo. I'm Tyler Andrews. That's Josiah Schweinberg. I think that's it. We'll see you guys next time.
Woo!